Hi, I'm Holly Stewart, and I'm going to talk to you today about Colic Workup. The talk will be geared strongly towards those practitioners going into a referral hospital setting, but there are a lot of tips that are applicable to new graduates and ambulatory practice as well. Additionally, I have a couple of cases for discussion at the end. In addition to talking about a colic workup, I've tried to highlight some veterinary tips and advice for client communication, as well as discuss some common mistakes and considerations you should have as a new graduate. I've highlighted vet advice in purple throughout the presentation, client communication tips in yellow, and questions for you to consider for further discussion are underlined in red. As a disclaimer, this talk reflects my training and experiences and may be different from what you have learned. I would say it's just another perspective for your professional toolbox. This is my general flow chart for working up a colic. The red lines are places where I try and stop and assess what needs to happen next in terms of diagnostics or treatments. This flowchart represents a comprehensive colic workup, and for field practitioners, I would say the focus is really on the left-hand column. I would say that a basic colic workup in the field involves a good history, thorough physical examination, and nasogastric intubation, as rectal palpation and blood work are not always possible or safe. This slide is a reminder about some of the things we will be talking about and focusing on during this general talk as well. Okay, so jumping now into the actual colic workup. When you get the call or the page saying that there's a vet who would like to refer a colic to you for further evaluation. My first piece of advice is to be positive when you answer the phone and when you're speaking to that particular vet. You may be exhausted, but never forget that you are a professional and you signed up for the job that you're in. You are also representing the practice that you're a part of, so be sure to keep that in mind when you're interacting with your referring vets. I usually answer the phone and say, "Hi," for this example, Dr. Smith, this is Dr. Holly Stewart. How are you, and what do you have for us this evening? That usually gives me time to get a pen and a piece of paper, and then I just listen to the information provided. It's really important to write down what the referring vet tells you, since it's really easy to get confused, especially on those nights when you're dealing with multiple colic cases. I usually circle back to my colic flowchart to make sure I have all the information about a colic that I can have. Try and get a sense of the horse's history, if this is the first colic episode or he's a repeat offender, what medications may have been administered, diagnostics performed, and I also find it helpful to ask the referring veterinarian about their working diagnosis for the case. It's also helpful to clarify if the referring veterinarian has passed a nasogastric tube and if they're leaving the tube in for shipping. Remember, if a nasogastric tube comes in with the horse, you are personally responsible for making sure it gets cleaned and sent back to that referring veterinarian by the next business day. I can't stress how far that gesture goes towards developing a professional relationship with an ambulatory clinician and demonstrating that you are professional and responsible. It's also good to make sure you know what medications have been administered by the referring veterinarian and the owners, and if the horse is being sedated for transport. Ask the referring veterinarian about how and when they would like to be updated. Many times a text after the workup will suffice, and then a call the next morning. The referring veterinarian can also tell you the plan for transporting the horse and who is coming with it. Sometimes they also know if the horse is insured or if the owners have financial limitations. I've had vets say that owners are bringing their horse in and are willing to go to surgery, so you can mention a general quote for colic surgery on the phone so the owners have some time to process that as well. It's also fair to ask for a 20 to 30 minute out call for the owners or the shippers, clarifying you'll provide specific instructions at that time regarding meeting them at the clinic. I realize it's a lot of information to discuss in a short period of time, but it can really help you to be completely prepared for the colic that you're about to see. Once you know a colic is coming, get yourself ready. You really should be prepared for your colic to arrive 20 minutes early or 2 hours late. Get yourself to the clinic or out of your room if you live above where you work. Get the lights on, the coffee brewing, the blood analyzers warmed up, and check in with any support staff or students you may have available. You can always direct people towards tasks that need to be taken care of and give everyone a bit of a summary of what to expect. Good communication coupled with a good attitude goes a long way. If it's late or your clinic is busy, everyone might be tired, but your attitude can really help rally the team, which only makes things get done quicker. Once everything is set up and ready to go, you can always plop down somewhere for a power nap until you get the out call from the owners or shippers. Make sure you provide specific instructions on where to meet once the owner or shipper arrives at the clinic. Providing these details really helps you be in control of the situation. And if napping isn't your style, or you're feeling like you aren't sure what to do or need some extra insight, think about grabbing one of these resources and having a quick read through. I found these books particularly valuable to read about what emergencies might walk through the door. Many of these you can get as ebooks or PDFs for pretty cheap online. Once the horse arrives, you should be outside to greet them with your team. Introduce yourself. A handshake goes a long way. And find out who has come with the horse and introduce who you are bringing into the room. If you have a large number of externs or fourth-year students that are visiting your clinic, it can be very concerning for the owners to see all those people in the room, especially in the middle of the night. If you're able to introduce everyone and give the owners a sense of their roles, it really helps the owner and client feel more comfortable with what's happening. I am also very transparent about the fact that I will be repeating some of the same things that their veterinarian did already in the field, explaining how colic can change rapidly. Remember that you are the senior presence in the room, and you need to lead by example. Do your best to stay calm, be in control, and be polite, no matter how crazy it gets. When you are working with other senior associates when you start at a practice, pay attention to how they handle stressful clients and situations. It can really help when you are on your own. From a veterinary perspective, you have the history from the referring vet, but remember, colic can change. Sometimes there are hours between when the referring veterinarian first saw the horse and when it gets to your clinic. You need to do your own medical assessment because that is the one that matters right now. You should be able to know how to work up a colic for $200 or $2,000. In the majority of academic hospitals, we tend to do everything on every colic, and that is not always the reality. During your first few months at a new practice, you should spend some time understanding how much everything costs at your practice. The best way to do this is to look at old, but recent, patient invoices, talk to other associates, and potentially even talk to your office manager about getting a more complete price list. This image right here is an example of the HVMS system, which is used by many private practice hospitals. Many equine hospitals are moving or have moved to digital record systems, so it's very easy to get an accurate pricing and generate invoices for specific cases. Remember, it's always better to overquote than underquote the client. Okay, so after all that, it's finally time to start working up the horse for colic. Remember, your colic workup starts right when the horse steps off the trailer with your visual exam. You are the vet in the room, and so you need to be focused on your workup. Is the horse safe to work up in the stocks or in a room, or do you need to consider moving to a recovery stall in case the horse tries to go down? This initial part of the workup can be somewhat chaotic, so remember that you need to communicate with everyone. Make sure your tech is holding the horse and focused on you, and that the owner knows you're going to start the workup. Despite everything going on, you still need to remember that you're a vet and you have a job to do. I have found it's helpful to recruit the owner to ask questions when needed, asking about the horse's normal attitude and finding out if the owner thinks the horse looks distended. I think doing this also helps the owner feel like you value hearing their opinion and what they have to say. I frequently say to owners, you know your horse better than I do, so please jump in and let me know what's normal for him or her. You'll be amazed at what the owners will tell you. It gives them a second to think about their horse and focus on something else other than the colic, and then they remember, oh, he had a new pasture mate, or we got a new shipment of hay recently, or whatever it is. It's also okay to politely tell the owner that you are trying to gather all the information before determining a diagnosis. Some owners want to know what you're finding every step of the way, and it's okay to say that you want to wait until you have all the information. It's most important when you first start out to be accurate, and then you can work on being efficient. I think the most successful clinicians are those that can both focus on what they're doing at that moment, but also be thinking about what they are doing next so that a workup flows smoothly and efficiently. By the end of your first year out of school, regardless of if you work in the field or in a hospital, you should be able to work up a colic efficiently. I don't want to give anyone a specific number of minutes for their colic workup because that's not really fair, and I don't want to encourage you to miss anything. Take the time you need to get the details from your thorough physical exam and tell the story of what's going on with your colic case. I know it's really easy to get tired, especially if it's almost midnight, you've worked all day, and you've already taken in or been managing half a dozen colics. Regardless, you need to think back, dig deep, and remember that this is your job and your efforts and accuracy matter. Even if the referring veterinarian has done the same diagnostics just an hour before, at minimum, you need to do a complete physical exam, pass a nasogastric tube, and perform palpation per rectum. Not that anyone wants to think about being sued, but I do think these things are pretty essential in a hospital setting for a colic workup. I think you may choose to skip rectal palpation in the field for safety, but again, it's very difficult to justify not passing a nasogastric tube. Once you pass the nasogastric tube and check for reflux, leave the tube in place so that you can have the option to use it and you don't need to go through the process to repass it once you have a plan. I've also learned to save a small amount of gastric contents, as this can be a more effective method to diagnose salmonella and clostridium compared to manure. For rectal palpation, be sure to use lots of lube and topical lidocaine if need be to get the best assessment possible. A rectal palpation for me usually takes 2 sleeves, as I will use the first sleeve to clean out the rectum and hold a fecal ball or 2 for a sedimentation test, and the second sleeve for palpation. Make sure you also check your sleeve for any evidence of blood after you've finished your palpation. Blood work is something that really isn't done in the field. Many ambulatory practitioners have an office where they can run some blood work, but typically only referral centers have the equipment to run full blood panels on site. I know we put a lot of emphasis on blood work in vet school, but you need to critically think about what you really need to answer or clarify what's going on with your case, especially because blood work is expensive. At minimum, you should run a PCV, total solids, and lactate on all colic cases, as this gives you a lot of information to work from. An abdominocentesis, or ab tap, or belly tap is not really something most practitioners will perform in the field. Although we do this a ton in the academic setting, it's not always necessary and may even be a higher risk for some patients. You should be thinking about who those patients are. If you do choose to perform an abdominocentesis, you should always evaluate your sample grossly and try to get a total solids and peritoneal lactate. A nucleated cell count and cytology can be helpful on these samples, but may be at an additional cost. All referral hospitals will have access to DIFQuick, stain, and a microscope, and you should be able to take your fluid sample, put it on a slide, stain it, and look at it under a microscope. It takes less than 15 minutes, and you can learn so much about what's actually going on. Ultrasound is another common diagnostic that we use a lot in the academic setting and can support the clinical suspicions you have from the previous aspects of your workup. As an aside, if you're not familiar with the relationship of peripheral and peritoneal lactate, you should definitely take a look at these publications. The ratio between these two values, as well as the raw numbers, can substantially help inform your clinical decision making. Additionally, if you have access to an ultrasound, I would encourage you to scan as many colic cases as possible during your first year. Again, this may not be a necessary diagnostic for your workup, but ultrasound, like any other imaging, is a skill. And so if you have the opportunity to develop this skill, it can be an incredible asset. When we talk about ultrasonography of colic cases, people typically talk about the FLASH technique, which is an acronym that stands for Fast, Localized, Abdominal Sonography of the Horse, or MFLASH, where the M stands for modified, which requires slightly fewer windows for evaluation. The two papers here describe this technique. This chart and table are pulled from the Busoni paper and can I would say we've covered the complete emergency workup for colic at a referral hospital up to this point. It's also worthwhile to think about what else you might want to do to reach a final diagnosis on a colic. There are other diagnostics such as oral or dental exam, endoscopy, abdominal radiographs, or a comprehensive abdominal ultrasound, or even an exploratory celiotomy that can be performed the following day, obviously, as long as your horse is stable. I think it's also important to consider these other diagnostics when you talk to an owner and think about your to-go-home recommendations. For example, in horses with repeat large colon impactions, I would recommend an oral or dental examinations, and occasionally I've found some very notable issues. Okay, so you've gone through the workup, but how much does it all actually cost? I think we do a very poor job of preparing veterinary students for talking about money. So I wanted to provide a cost analysis for working up a colic from some of the places where I have worked, which include a private practice referral hospital, as well as multiple academic institutions. These are some example prices for what it costs to perform a colic workup. Many hospitals have an emergency fee that is cheaper during the day compared to the middle of the night. Hospitals may also have an admission fee, which covers the costs associated with the horse being on the property and then also covers supplies and staff required to handle that emergency. Your professional costs are typically included in the colic workup fee or something similar. This covers the very basics, your physical examination, passing the nasogastric tube, and your rectal palpation. No drugs or medications are covered in this price. Blood work for a colic is surprisingly expensive, and this can be a place where you can cut costs if you only perform a limited number of tests. Sedation, drugs, and other medications vary in their price and availability, but multiple doses of multiple things do add up. Ultrasound is occasionally included in a colic workup fee, but most places have this as a separate cost. If this is the case, you need to do everything in your power to make that diagnostic worth the additional money for the client. Save images that you can talk through later, and do what you need to do, which includes clipping, to make sure you see what you need to see in your abdominal windows. That will make more sense once you learn how to do the FLASH technique. Again, abdominocentesis is not required for all colics, but can be very helpful. Be aware that this can be close to a $200 diagnostic when you include fluid analysis. Occasionally, we do perform serial abdominocenteses to understand how the abdominal environment may be changing, and this does add up. As I mentioned before, you need to learn the prices for the hospital where you are working. And if finances are a limiting factor for the client, which is true for many people, you need to know how to make the dollars stretch. And if we add everything we discussed just previously for a colic workup together, we are close to $1,000 just to admit and look at the horse, which doesn't even include treatment. Okay, now you need to make a plan for what you want to do. You've seen the horse and performed your evaluation, identifying what is normal and what is abnormal. Now, as the vet, you need to put all that information together and come up with both a working diagnosis and a plan for treatment. I always try to create a list of 3 prioritized differentials. If you're not sure what differentials to consider, I would encourage you to read back through those textbooks I had suggested earlier to help come up with a working diagnosis. I will also mention that we call it a working diagnosis because your diagnosis can change over time. You may have a horse that comes in moderately painful but stable, and you diagnose a displacement, and then a few hours later, the horse is extremely painful, as now it has a large colon volvulus. Once you have your working diagnosis and plan, you need to consider the avenue for treatment. Is this a medical or a surgical problem? It's also important to keep in mind that regardless of the lesion, if we are unable to manage a horse's pain, we recommend surgery, or in some cases, humane euthanasia. So for example, you may have a horse with a nephrosplenic entrapment, and you personally think it should be able to resolve without surgery. Well, if the horse is so painful it can't stand and is self-traumatizing due to pain, it needs to go to surgery. It's really important that we all remember that we, as veterinarians, are stewards for the humane and ethical treatment of these animals. We need to keep the welfare of these animals in mind, which can be challenging, especially with an emotionally distressed owner. So once you have your working diagnosis and proposed plan, you need to put everything together in a focused summary for the owner. I try and focus on 3 important things to tell the owner, as details frequently get lost or misremembered. So I might start by saying something like, after taking a look at your horse, I believe he has a large colon impaction. The good news is that his blood work and other diagnostics would suggest that he is systemically stable and the impaction is still indentable on rectal palpation. I think it's worthwhile to try medically managing him, and I would recommend enteral and IV fluids, as well as analgesics and some sedation. Remember, it is your job to present a diagnosis based on your workup and have different options for treatment plans. It is not your job to make a decision about how the owner should treat this horse. With that said, regardless of the decision the owners make, you need to provide support and compassion, even if you would make a different decision if you were in their shoes. Always give owners a chance to ask more questions or talk through each diagnostic individually. You also need to be prepared to talk about the prognosis and cost. If they take their horse to surgery, can they still expect him to compete at 4th level dressage? What does the timing look like for recovery, and when can he get back to work? You don't need to answer every question in excruciating detail on the night of admission, but you need to be able to give some idea about what the owners should expect. If you're not sure about outcome and prognoses for some types of colic, I would encourage you to check out these articles that can give you details for specific types of lesions. The textbooks I also suggested also has this information. And when thinking about costs for treatment, I've given some cost examples here. Again, prices may vary depending on where you are, but enteral fluids are obviously much cheaper than IV fluids, which include the IV catheter, fluid lines, and add-ins, in addition to the cost of the fluids themselves. Again, you should take some time to familiarize yourself with the prices at your clinic so you know just how much you're spending on a given patient for a given treatment plan. These are some general quotes that are fairly standard across the country right now. I think regardless of whether or not you treat a horse medically or surgically, you need to watch the bill carefully and update the owner daily. It's also really important to warn owners that some medical colics can cost just as much as a surgical colic, since sometimes owners decide to proceed with medical care over surgical care, thinking that it will be cheaper. Talking about money with an owner can be a tough conversation, but that is part of your job. It's also important to give owners a realistic view of what is happening with their horse, even if the updates aren't what they want to hear. For all cases, but especially if you have an owner that has a hard money limit of what they can spend, it's important that they have a realistic understanding of what's happening to their animal and how their money is being spent. And I want to prepare you for the fact that you may need or want advice about a case. I would absolutely encourage everyone to use the resources they have available. You can learn a ton from asking questions of people who have been doing this longer than you. When I'm in a situation where I don't quite know what to do, I like to say something like, one of the benefits of coming to this hospital is that you have multiple veterinarians working on each case. I'm going to give Dr. Y a call and get their opinion about your horse before we move forward. Saying something like that is a lot better than telling an owner you don't know what's going on with their horse. Now, when you do call for advice, you need to be organized. It's not enough to just tell your associate or the surgeon on call what you found. You need to have a concise summary about the case, highlighting the relevant diagnostic findings, your working diagnosis, and your proposed plan, in addition to your questions. You need to be able to think about the case you have and provide an assessment, not just report the diagnostic facts. That's what distinguishes an actual veterinarian from a fourth-year veterinary student. Depending on where you work, that associate may be able to come into the hospital to provide a second opinion. If they do this, make sure everything is prepped and ready for them. The rectal sleeve is ready, the room is tidied. Sometimes the surgeon on call will want to do their own assessment before agreeing to take a horse to surgery, and that's totally okay. There's no reason to be offended or upset if this is the policy. You should embrace it as a time to hear their opinion and compare your assessment to theirs. So after all that, you now have a diagnosis and a plan. In some ways, now the actual work begins. You need to take full responsibility for executing the plan you put in place. Now, that doesn't mean that you need to do everything yourself, but you need to work with your technicians and your externs to make sure the horse receives the highest quality of care that you can provide. And don't get too stuck on your plan. You need to focus on what your patient is telling you, which may change rapidly over the course of a few hours. Don't be afraid to start all over again with your workup and assessment, starting with your physical examination. Over time, you will start to notice patterns for certain types of cases, but don't let this make you overconfident. You need to treat every horse and every case as unique and create a plan that works for that case on that day. So after all that, I have 3 take-home messages before we get into a case discussion. First, you are still learning, and I am too. You need to own that you don't know it all and embrace the discomfort that goes with it. That doesn't mean, it means, that you need to be humble enough to ask for help when you don't know something. Second, your attitude matters. From today forward, start acting like the vet you want to be or the vet you look up to. It's important to be compassionate and polite and communicative. Your attitude goes a long way with your colleagues and your clients, especially in the middle of the night. Third, be prepared. Regardless of what practice you go into, you will see a lot of colic cases. It's one of the things that goes with being a new intern or a new associate. Push yourself, no matter how tired you are, to learn something new from every single case you see. You will be so much better off after your first year if you do. So now I wanted to transition and run through a couple of cases. We only have time to discuss 2. These are real clinical cases that I've seen, and there are lots of red underlined questions for you to consider, not all of which I will answer. These cases are definitely more nuanced than what you may have discussed in classes, so really push yourself to use the next slides as an exercise to think through these cases. Colic case number 1. He really doesn't seem that bad, Doc. So the first case is a 9-year-old quarter horse gelding. The owner reports he was normal this morning and then has become more painful during the day. A referring veterinarian has not seen this horse in the field, The owners just put the horse on the trailer and headed to your referral hospital for your evaluation. You should be thinking about what other questions you'd like to ask the owner and what you'd like to know. On arrival, the horse is quiet with a dull attitude. You can visually see the horse is dripping with sweat and looks uncomfortable. He's thinking about laying down, but isn't actively throwing himself to the ground. You wonder if he's potentially profoundly stoic. You perform a physical exam and you find a markedly elevated heart rate, elevated respiratory rate and effort with a normal rectal temperature. Borborygmi are present but decrease throughout the abdomen, and the horse does not look overly distended. What's your next diagnostic and why? Okay, that question really should have been a gimme. Based on the horse's high heart rate, I would recommend you pass a nasogastric tube first. You don't get any gastric reflux, and after gastric lavage, the horse still has an elevated heart rate. Palpation per rectum reveals a soft colon, and all palpable bowel is in the correct place. Basic blood work shows a PCV of 48, total solids of 5.6, and lactate of 2.2. What else do you want to know on this horse when it comes to blood work? Well, for the sake of time, I will give you a CBC and chemistry on this horse. I've left off a few CBC values and a few chemistry values for the sake of simplicity, but this should be sufficient for our discussion. I've also given you the normal ranges, but you will find you may not need them over time as you look at more and more blood work. Also note that the normal ranges reported here are for an adult horse, and they would be different if this were a foal. So when I have a complete blood work panel, I do a run through and I make note of what's abnormal, and then I think about if I can explain the abnormality based on what I've learned from my diagnostics. So I'll give you a quick second to look at that. And here are the chemistry values with the normal ranges, so you can take a look at that and figure out what's abnormal or concerning. Okay, so at this point, you've completed a basic colic workup with blood work. What are your differentials? You should be able to at least lean towards something or have a few differentials that you would like to think about. Are there additional diagnostics that you want to do? If so, what are they and in what order? Unfortunately, I can't poll you as you're all listening right now, so I'll give you a complete colic workup with all the diagnostics for this case. Your abdominocentesis reveals serosanguinous peritoneal fluid with a nucleated cell count of 3,500, total solids of 3.2, and a lactate of 5. Your ultrasound reveals normal small intestine in the inguinal region, a visible left kidney, and a colon with a normal wall thickness on both the left and the right. So now, putting all this together, what are your differentials for this colic, and what is your plan? No, seriously, you need to start pushing yourself and putting the picture together and making a plan based on what you think is going on. Okay, so I'll provide you a little bit more information about how this case progressed. The horse required multiple doses of sedation to perform the diagnostics and remains persistently uncomfortable. So you place an IV catheter and you start fluids. You recommend surgery for this horse based on the inability to manage pain. As an important reminder, your recommendation to take a horse to surgery might completely excite you, but it may be very overwhelming for the owner. Remember that in the way you talk to a client. It's important to speak clearly and directly about the plan, but you still need to be compassionate during this process. So given the fact that you have recommended surgery, what's your preoperative plan for this horse? What else do you need to do to prepare this horse for surgery? There are horse-related items you need to do and client-related items you need to consider, such as coming up with a communication plan for when you're updating the owner and collecting a deposit for surgery, which typically is half the low end of the estimate. Okay, so you take the horse to surgery and you find an epiploic foramen entrapment of the distal small intestine, including the proximate ileum and distal. This white, abnormally distended piece of small intestine was the segment of bowel that was entrapped in the epiploic space. That distended piece of bowel is not viable, so you need to go ahead and perform a jejuno-ileostomy, removing about 5 feet of bowel. Depending on the case, the head surgeon may choose to update the owner before the resection, as this will change the cost estimate and potential complications for the horse. We will assume that the owner gives permission and that the resection goes well. You finish the remainder of the exploratory coleotomy and begin to close the abdomen. As a piece of vet advice, closure is the ideal time to talk to the senior surgeon about a post-operative plan for the horse. There is not a uniform post-operative plan for all colic cases, but you will find similarities among surgeons and types of cases. You should also be thinking about what you might want to tell the owner after surgery about what they can expect. For this case, you can go back and think about what questions you could have asked the owner and try to find the signs in the workup that might lead you to have this as a differential diagnosis. If you aren't familiar with the epiploic foramen or epiploic foramen entrapments, here are a few manuscripts to consider reading to get a better understanding of this condition. David Freeman out of Florida has also published extensively on the anatomy of this space, which is worth checking out too. Okay, now on to our second case. The quotes I've included here are real quotes that owners will say on the phone to you. It's important to listen to what the owners are saying. Sometimes it's great information about what's going on with the horse, and sometimes it's great information about what's going on with the owner and how they're feeling and what they might need from a support perspective during the colic process. So our second case is a 12-year-old warm blood mare. She's been quieter in the past few days, but eating normally. The owner received a secondhand message from the trainer that she didn't pass much manure overnight. The trainer had the vet come out midday to look at the horse, and then the owner came out and watched the horse after work. What else do you need to ask about this case to get a complete picture of what's going on? Remember, horses colic when they have a change in work or activity, a change in feed, or a change in environment. Those are usually good areas to start with your questions. On admission, the mare is visibly uncomfortable and also anxious. She has some abnormalities on physical examination with a moderately elevated heart rate, slightly tacky mucous membranes, and decreased borborygmi. Based on these findings, what would you elect to do next and why? I would say it's reasonable to begin with palpation per rectum, but you wouldn't be wrong if you elected to pass the nasogastric tube first. On palpation per rectum, you find dry mucus-covered fecal balls within the rectum and a large, smooth viscus centrally and on the left side of the abdomen. You obtain 3 liters of gastric reflux on nasogastric intubation, and your basic blood work shows a PCV of 52, total solids of 6.6, and a lactate of 1.2. Do you think further diagnostics are warranted in this case? And if so, what would you like to know? You need to ask yourself if having more diagnostics is really going to inform your medical plan. If it doesn't change your diagnosis or how you plan to manage the case, then you need to ask yourself if it's really appropriate to perform them. I won't tell you the answer about whether you need to do more diagnostics or not, but I think you should all be thinking about the questions I've posed. You go ahead and you tell the owner you believe the horse has a large colon impaction and you would recommend fluid therapy. What are your current recommendations and what's a cost estimate for this horse? We will say that you elect for both enteral and IV fluids. which you start for the horse and then put her in a stall. It's getting to be late into the evening, and the mare is starting to look uncomfortable, and she's getting up and down in the stall. When she's down, she isn't thrashing or rolling. She's in lateral or in sternal, but she's constantly shifting her weight and looking at her flank when she's standing. You repeat some of your initial diagnostics to get a sense of what's going on. Now, what do you plan to do? So who's voting to take this mare to surgery, and who is voting to medically manage this mare? I would say it's a judgment call about what you want to do. It's also fair to call and consult with the surgeon on call to get their opinion on how they like to handle these cases. I think there are some arguments that can be made for either medical or surgical management, as both directions have some risk and some benefit in this case. I would probably choose to medically manage this horse because I do expect some discomfort as the horse is working through an impaction. Given the time of night, the Banamine administered by the referring veterinarian may be wearing off, and you can consider repeating a dose or giving a dose of sedation. I typically don't take large colon impactions to surgery if they have borborygmi, even if it's decreased throughout the abdomen, as long as it's there. I would recommend repeating some additional diagnostics for the horse since colonic impactions can displace, which makes them more painful. As I mentioned before, if you are at a referral hospital, you can always consult with the senior or surgeon who's on for the evening. If you're in the field, I would recommend referral after 2 visits to see a horse for the sake of your sanity as well. We'll say you choose to sedate the horse and monitor her response to treatment. She quiets down with the sedation and still seems uncomfortable but is manageable. She begins passing manure and continues to do so overnight. In the morning at barn rounds, your senior clinician asks if the case is sorted and done and ready for discharge. What are you going to say, and what else might you like to do? I won't give you the answers to those questions, but I'm happy to discuss them further if people are interested. Here are some additional peer-reviewed resources that you can use for thinking about colonic colic cases, including large colon impactions. And with that, I'd like to thank you for your attention and time listening to this webinar, and my contact information is here in case you would like to reach out to me with any additional questions or concerns about this presentation or otherwise. I'm happy to talk further about my personal experiences, so feel free to use me as a resource if I can be helpful to anyone in any way. Thank you so much for your time, and have a great day.